Good afternoon, everyone. My name is Moises Agosto Rosario, and I'm the Director of Treatment for IMMAC, formerly known as the National Minority AIDS Council. I'm also the lead staff for our HIV Strong and Healthy program, which is a program that address issues related to HIV and aging. We have programmatic interventions like the mini grants, we have the webinars like this one. We also are linked to the National HIV Aging and Advocacy Network. And we also do work around advocacy and any policy issue related to aging and HIV. As everybody knows, today in the United States, more than 50% of the people living with HIV are individuals HIV 50 plus and long-term survivors. And it is projected that by 2030, it will become to 30%, 70% of those living with HIV. So this is a very important topic, as this population will continue to increase, and the needs for people living with HIV will need to have to adjust and be rethought of in terms of like how we best serve to the first cohort of people living with HIV that are over the age of 50. In this also with long-term survivors, we include those known as verticals, that are people that were born with HIV, and that even though they're in their 30s and 40s, they have been living with HIV for more than a lot of them 30 years. So today we are presenting a webinar around issues related to policy and advocacy related to aging and HIV and long-term survivors. And we have a great panel. This is we're going to be talking with individuals that are working from the policy point of view, but also that they are part of a network of individuals that are HIV 50 plus and long-term survivors. So I know everybody is very eager to hear them and know what they have to tell us about what are the things that we need to understand about policy and what are the things that we need to advocate for. So I'm going to start introducing you, the panelists. I'm going to start with Vanessa Johnson. I will let them introduce themselves very briefly. And Vanessa, if you can pass it to some of the panelists, that would be great.
Okay, thank you, Moses, and thank you for the invitation to be with you all this afternoon. My name is Vanessa Johnson. I'm a co-executive director at Ribbon. I share that position with Linda H. Scruggs, who's unable to be with us today. I serve on a number of national and regional bodies that are designed to improve service delivery for people living with HIV, and I'm a proud founder and member of the United States People Living with HIV Caucus. I live in Washington, D.C., by the way. So I'm going to pass this to Tom to introduce himself.
Thank you. My name is Tom Villa. I'm a co-chair and member of the executive committee of the National HIV and Aging Advocacy Network, which we will speak about a little bit later, was born out of this very HIV 50 plus program. I'm also a person living with HIV for more than the past 20 years and serve in a number of capacities related to HIV research, particularly on the Martin Delaney collaboratories, several of those, HOPE, BELIEVE, and RID, all focused on developing various strategies that will eventually lead, we hope, to curing HIV. And I participate in and serve on other community advisory boards for various research projects focused on HIV prevention and also treatment and care of people who are living and aging with HIV. So very happy to be here today, and I'll pass this to Joe.
Thank you, Tom. Hello, everybody. My name is Joe Huang Ricalto. I am a policy and partnership director here at NMAC. Great to be here today. I'm also a long-term survivor. Just a little note about me. After about 23 years, I retired. After 23 years, I retired from the Hill, where while I was there, I worked with my very first boss, former Senator Ted Kennedy, on the reauthorization of Ryan White. We also worked on, obviously, tremendously successful civil rights civil rights legislation. And ironically, I think this position was opened in 2008, a funny fact. And I was about ready to leave the Hill, but we had just won the House, and my boss was about to ready to become chairman. So I didn't leave. I stayed for my retirement. And then after I retired, I saw the position again. I said to Moises, if the other candidate's name is Barack Obama, I still want the job. So it's good to be here. And I will pass it over to you, Ron.
Thank you. Thank you, Joe, and welcome everyone. My name is Ronald Johnson. I am a older adult, long-term survivor living with HIV. I chair the U.S. People Living with HIV Caucus. I also work on HIV and aging issues with AIDS United and also on the expert panel, advisory panel, and work for and help out Association for Nurses in AIDS Care. And that keeps me a little busy, all of those things. Having retired from a position at AIDS United about 4 years ago, where I was the Vice President of Policy and Advocacy. And I am a resident of Silver Spring, Maryland. So I will pass it back to Moises.
As you can see, we have a stellar panel. I can't wait. So the order of the presentations, we're going to start with Ronald, and he's going to be talking about, the work that is happening with AIDS United. He's the author of a great report on aging and policy issues, and also he will be talking about the coalition panel that AIDS United has. And also give us a sense of what are those big issues on policy. And then we're going to pass it to Vanessa. And Vanessa is also going to talk about policy issues in that context of what are the advocacy specific needs. I hope that there is some talk about policy, aging, and women. And then from Vanessa, we're going to go to Joe, who's going to talk to us about legislative activities around aging and HIV. And then last but not least, we're going to have Tom, who's going to talk from his work around research, but also from the perspective of the network, the National HIV Aging and Advocacy Network. So with that, I'm going to pass it to Ronald. So take it away.
Thanks, Moises. And if my slides can be put up. Yes, as Moises indicated, I'm going to be starting off by talking about HIV and aging from a state level advocacy perspective. And next slide. I'm going to start by noting the increased focus on HIV and aging over the past 3 years. Much of that is driven by, as Moises indicated, the growth in the number and the proportion of those of us who are living with HIV who are 50 years and older, and now making up about 50% of all people living with HIV, and that the percentage as well as the number is growing and will get to about 70% in a few years. And so that really is driving the increased focus on HIV and aging, too long neglected issue. But we currently, as a result of this increased focus and attention, we already know a great deal about HIV and aging and about the needs of older adults living with HIV and also long-term survivors of HIV who are less than 50 years of age. And that includes, as Moises mentioned, the verticals, those who were born with HIV and are now in their 20s and 30s and thus have been living with HIV for 20 and 30 years. We still have a lot more to know about just the the science of HIV and aging and the effects, and we have increased awareness of the needs and concerns, but we already know a great deal. We've seen funding increased and focused on HIV and aging. Many of grantees from the Gilead has been funding HIV and aging projects. Other foundations and corporations are beginning to focus on that. Grant makers concerned about funding, I'm botching their name, my apologies, but they put out a paper about grant making around HIV and aging and various government, federal programs that have been focused on that. And increased advocacy on HIV and aging. The number of national coalitions and networks, Moises mentioned HIV Strong and Healthy, Tom's organization. I'll be talking about a coalition, HIV AIDS Policy Action Coalition. There are state coalitions. I'm a member of the Maryland Coalition on HIV and Aging, and many, many local networks. So the focus on HIV and aging really has increased. Next slide. As I mentioned, I want to talk about the one coalition, HIV AIDS Policy Coalition, Action Coalition. This coalition was formed about 2019, was first organized by SAGE under their HIV and Aging project, and is currently being supported by AIDS United. The policy focus of the Policy Action Coalition, not surprisingly, is on policy. And one of the targets of the policy for HAPAC, as the coalition is called, is promoting and focusing on state-level advocacy on HIV and aging, with a particular priority of increasing state support for programs and services for older adults living with HIV and long-term survivors. And I think this focus on the state and getting more states' involvement is a critical part of the current landscape of HIV and aging and the policy and advocacy related to HIV and aging. Next slide. When we look at state level advocacy, that really does bring up a key part of what I see is the emerging and the broadening of our purview around HIV and aging to include aging issues. And certainly the Older Americans Act comes into play and ought to come into play when we talk about broadening the landscape of opportunities to focus on HIV and aging and the relationship between HIV and the aging process. A key part of the Older Americans Act is supporting and the grants to all of the states and the District of Columbia. And the Older Americans Act has a provision that, as the slide says, shows focus on identifying populations of greatest economic need and populations with greatest social need, with a particular attention to low-income older adults and minority older adults and older adults living in rural areas. So with that focus and with the increasing number of those of us who are aging and over 50, over 60, some of us are over 70 with HIV, the opportunities and responsibilities, I think, for under the Older Americans Act come into play. Next slide. And the agency that within the Health and Human Services Department that has the Older Americans Act under its purview and is authorized by that act, the Administration for Community Living and in the Administration on Aging has a great deal of responsibility for the implementation of the Older Americans Act and funding to the states. Last year, the ACL put out a new state plan guidance for the states, for states plans for the year beginning in October. Each state has to develop a plan on aging. And this guidance encouraged states, and this is the first time that a national guidance specifically mentioned older adults in greater social needs, including LGBTQ plus older adults, and required states to include in future state plans, and that future is now October 2022. This guidance, as I said, was issued last year, but starting in October, states plans have to state how they are serving older adults living with HIV and AIDS. And this requirement ought to be, and I think it is, a really a cue to HIV advocates that we need to be taking attention, we need to pay attention to these state plans. And that's some of the priorities of HAPAC is how do we monitor, how do we hold states accountable? Next slide. So some of the policy objectives that HAPAC Coalition is talking about and working on, and hopefully other advocates will also work on this. How do we increase the number of states that have designated older adults living with HIV as a population in greatest social need, and to tap into the opportunities that such a designation would have under the Older Americans Act, as well as making sure that older adults living with HIV are fully incorporated and their programs to serve older adults living with HIV are supported by the states. Currently, only 2 states and the District of Columbia have acted to make older adults living with HIV a population of greatest social need. Illinois was the first state. California also has moved in that direction, and the District of Columbia. A number of states are percolating ideas and plans, and they certainly need to be encouraged. But I think, again, advocacy at the state level to get more numbers, more states, all 50 states would be ideal, to designate older adults living with HIV as a population on greatest social need, and also monitoring state plans to hold states accountable for how they serve older adults. That is a key job of we as advocates, holding states accountable for the requirement that they tell how they are serving, and to the extent that they are serving older adults. We need to hold them accountable. Next slide. But as I said, we have an increased focus on HIV and aging, and including state level advocacy in that, but we need to do more at all levels, national, state, and local. Too many of us are experiencing neglect. Healthcare systems are not up to par completely where they need to be, where they must be in terms of serving the medical needs, the social needs, addressing social isolation, mental health issues. There's a lot of work we still need to do, whether it's at the state level, as HAPAC and others are doing, at the national level, as many of us are doing, and certainly at the local level. We must do more. We must take advantage of this increased focus, but it's time to act. It's time to make the changes that are so necessary. And part of that means the meaningful involvement of those of us living with HIV needs to be centered. We need to be involved in the advocacy. We need to be involved in the policy making. We need to be involved in setting the kinds of programs and making sure that they meet our needs and those that are right behind us who will be turning 50 and turning 60. If the population is growing, the increased focus is growing, we need to make changes. And I'm sure my colleagues on this panel will talk more about that, and I look forward to a vigorous question and answer period. Thank you.
Thank you, Ronald, and excellent presentation. And yes, I hope that everybody take the opportunity to bring questions along now that we are all together here. So our next presentation is going to be Vanessa. So Vanessa, please take it over.
All right. I thank you. So I am, as I said, with Ribbon. I am a 32-year long-term survivor of HIV. So I'm beginning to have a lot of experience with aging and living with HIV. So it's not surprising to me that Ribbon is has been funded to organize an initiative around Gilead's HIV Age Positively initiative called ROC, which is Ribbon Organizing Center for Aging. And we're going to talk about the policy needs and current advocacy efforts for people living with HIV. Next slide. So here are the purpose and goals. I'm not going to read them entirely, other than to say that the purpose of Ribbon's Organizing Center is to thoroughly commit to increasing the visibility and leadership of people living with HIV over 50 and the organizations involved in HIV and aging work in the United States. We have 3 goals, and I'm sure if you would like to examine this PowerPoint deck more thoroughly, you can do so by requesting it through myself or through IMMAC. Next slide. We consist of 3 action groups, and technology is always surprising, but ROC provides training and technical assistance to the 23 grantees across the United States who are being funded by Gilead Sciences. In addition to that, we also have an advisory group called the National Community Action Group, or NCAB, which is the body that provides ROC with its direction, and they're in the process of developing a strategic plan that will guide the group's work and ROC's work for the next 3 years. Under that body are 3 action groups: program, policy, and communications. And I'm going to talk about the work that the policy committee has been doing, or policy action group has been doing. Next slide. So we're going to have a couple talking points today. I'm going to read from some notes that I have. I want to say before I begin that the policy action group is chaired by William McCall, who many of you may know is a longtime HIV policy expert. That's what I think he is. And we're very happy to have him. I serve as staff support for that group. We're going to talk about the numbers, what we're facing, and what we need. And I want to start out in the words of one of our policy action group members, Jules Levin, who says that aging and elderly people living with HIV need action now. ROC and its policy action group could not agree more with him. The remarks I'm about to make refer to my own experiences, as I said, as a 32-year-old long-term survivor of HIV, and the work of the National AIDS Treatment Advocacy Program, HRSA, the United Nations campaign to implement universal health care coverage, the American Heart Association, and the Infectious Disease Society of America and the HIV Medicine Association, who did a wonderful paper called The Principles for Ending HIV as an Epidemic in the United States. I encourage you all to read that paper as well. It's a great policy paper. So we're going to talk about the numbers. We are currently at 200,000 people living with HIV, over 60 in the United States. I said over 60. That does not include the number of people living with HIV who are over 50. This number, over 60, is expected to grow by 400,000 in 2030. As you may already know, many are experiencing declines in mental and physical health. Many are suffering from mental and physical disabilities and are unable to perform daily routine activities. People living with HIV have double the rates compared to the general population for many chronic health conditions. Furthermore, the large Kaiser Permanente study that was presented at CROI in 2020 reported that 20 to 15 years is the onset for significant comorbidities. That's earlier than the general population at 10 to 15 years. And lastly, HRSA published a paper finding 3 to 6 times higher death rates among people living with HIV on Medicare and higher comorbidities. Interventions to ensure high quality care and address underlying chronic illnesses have improved the survival rate of people living with HIV. So we can't say that work hasn't been done, but definitely more has to be done. We have the knowledge and the know-how, but we lack the will to invest in the lives of people we have found to be expendable for too long a period of time. We know that our country must improve care for aging and elderly people living with HIV. In addition to the established standard of care for people living with HIV, the standard for people living with HIV 50 and over must also include geriatric screenings and evaluations, including bone density testing, as well as frailty and cognitive evaluation. Excuse me for that. Regarding research, the people living with HIV community requires implementation studies that provide real-time access to care and services for aging and elderly, like physical rehabilitation, exercise, healthy eating, and support programs for isolation and loneliness. So what are we facing? We are facing a healthcare infrastructure which is inadequate and antiquated and inaccessible, and we are losing ground. Life expectancy is decreasing in this country. If you have been paying attention to the news, they have been talking about that. They want to limit that just to COVID, the reasons why that might be so, and unintentional drug overdoses. But if those of us who have been working in the field of HIV know that social determinants of health are also contributing to this decline in life expectancy. Why? Blacks and whites in the United States, there is a difference of 40% in life expectancy. In addition, members of the LGBT community and women experience barriers disproportionate to health care and coverage compared with the general population, and they have a higher prevalence of chronic diseases. We know that there's a problem with insurance reimbursement for both public and private insurance. And in recent years, it has become increasingly limited and restricted in terms of the care they can provide, as evident by the amount of time a physician, our primary care source of care, can provide care to us. We have an Ryan White Care Act program, which is funded at $1 billion, that is supposed to meet the needs of all the people living with HIV, but that's only if they're income eligible. And we'll talk about that in a minute in terms of an advocacy point. So what do we need? We need real healthcare reform. We started this process in 1912, and we found ourselves sporadically making progress until we made some substantial progress in 2010 when the Affordable Care Act was enacted. Unfortunately, the Affordable Care Act is not uniformly implemented across the nation, and many states in the South have blocked Medicaid expansion. We can't stop here. We must work to ensure that health care, including access to preventive services, mental health services, substance use, and harm reduction services, is adequate, accessible, and affordable for everyone, regardless of health status and pay status. If not, instead of becoming the home of the free and the brave, or rather I should say, instead of remaining the home of the free and the brave, we will increasingly become the home of the discarded and the fearful. In the meantime, while we fight for universal health care coverage, let's advocate for the expansion of Ryan White clinics that provide geriatric and specialty care to people living with HIV 50 and over. HRSA, New York State, New York City, and various other entities are establishing such clinics, but additional dollars are required for long-term investment in an aging population. We have to expand the field of peer patient navigators to serve as guides and conduits to a current healthcare system that is overwhelming, confusing, and often not welcoming. Health and social care systems were designed by people with single and acute diseases, but we, as older adults, are faced with multiple long-term conditions. The process of navigating these current healthcare systems just dissuades us from staying in care. The last point I would like to make is that, and I've talked to some of the colleagues that are doing the presentation today and hope that we can continue this discussion, is advocating for a pilot demonstration project which explores eliminating income eligibility criteria for people over 50, but who are still too young for Medicare under the Ryan White program. I thank you for this opportunity to talk about ROC, which is Ribbon's organizing center, and to talk about the condition of people living with HIV over 50. Thank you very much.
Excellent, Vanessa. Thank you so much for your presentation. Now, I'm going to pass it to Joe.
Hello, can you hear me? I think you can. Yeah.
Yes,
All
we
right.
can.
Thanks, Moises and Vanessa and Ron. Thank you. I want to piggyback and expand a little bit more about what Ron said on Older Americans Act, because as you will see in the next year or two, NMAC is going to be spending considerable amount of time and resources to try and get HIV included in the OAA in some form or another. And I'll get into the details of that. But just a little history before I go into kind of a more concentrated explanation of the policies, the politics surrounding OAA. I just want to kind of give you maybe a one or two sentence to capitalize on the importance here. But it was, I think, back in 1965, Congress created the OAA. It's a federal program specifically designed to meet the social service needs of older persons. In a response to that concern about a lack of community social services for older persons, Congress obviously adopted the OAA, which over the course of the year since 65 has been amended several times to include many chronic illnesses and or inflictions. And we'll get into more of that in a few minutes here as well. But basically the OAA, which is the acronym for Older Americans Act, authorizes funding based primarily on the percentage of an area's population 60 and older for supportive services, nutritional services such as meals served at group sites such as senior centers, community centers, schools, churches, etc. They also provide home delivered nutritional services. They also provide family caregiver support and community services such as employment, long-term care programs, etc. Of particular interest to what we're doing are programs funded by within Title III and somewhat Title VII of the OAA. They provide a broad range of services to older adults. For example, Title III of the OAA authorizes grants to states and area agencies on aging to act as advocates. So in other words, these centers serve as advocates for those constituents, older persons over the age of 60. A particular interest that I thought you all would be interested in is Title III accounted for 73% of all of OAA's funding. For example, in FY21, the Older Americans Act was funded at 2.13, I think 2.129 or 2.13 billion. Out of that, Title III of that act got 1.56 billion. Well, and it should be noted that while all adults over the age of 60 are entitled for services, the OAA, Title III of the OAA, requires programs to target or prioritize service to older individuals with the greatest economic and social need. This is where we're going to kind of, the rubber meets the road. Some of those needs already in statute are living at or below poverty, the poverty threshold, having a physical or mental disability that poses a risk for institutional placement, or impacted cultural, and this is important, social or geographical isolation, including isolation caused by language, race, and ethnic status. And as Ron said, states are required to consider such factors when developing the intrastate formulas, the grants they use to allocate fund among their local agencies. The goal here for NMAC is, the goal of our effort is to enable the Older Americans Act programs to prioritize adults age 60 and older who are living with HIV and AIDS. Currently, and this is very important, especially because of the 5th District Court that's taken up that horrific case in Texas, there is no statutory requirement in the OAA that specifically directs focus on HIV and AIDS. And that's a concern for us. So here's our approach at NMAC. There are two possible approaches. First is to seek to add HIV to the list of chronic diseases. Personally, that's the preference for me. Currently in statute, so we want to put that currently in statute. The second is to add, as Ron said, add an individual's HIV status within the scope of, quote, what's known as the greatest social need. And after researching both approaches, you know, we would recommend some initial, well, we did some initial meetings with relevant federal agency. We also reached out to stakeholders. We have ongoing meetings to build support to include this. I want to talk a little bit more now about the chronic diseases component. The Assistant Secretary, the OAA says basically the Assistant Secretary shall carry out a program for making grants to states under state plans that Ron noted, approved by the title, to provide, quote, evidence-based disease prevention and health promotion services. And then within the Act of OAA, that is defined by evidence-based health promotion programs, including programs related to the prevention and mitigation of the effects, and I can provide all of this to anybody that wishes to see it, of chronic diseases. In the current statute, it says osteoporosis, hypertension, obesity, diabetes, and cardiovascular disease. And this is important because it also includes infectious disease and vaccine preventable disease, prevention of sexually transmitted diseases, as well as alcohol and substance abuse reduction, chronic pain management, smoking cessation, weight loss. So what I'm doing is I'm reading off a list of conditions and diseases that are currently listed in there. There is some kind of friction. There is some friction within Congress. I will note that because it lists infectious diseases, that theoretically the HIV community and those of us who are over 50, although we haven't met the threshold, well, I haven't yet, of the 60, so I'd be eligible for OAA intervention. But there is a lot of debate within Congress because HIV is, of course, is categorized as an infectious disease. And so their concern there is that once they open that floodgate, so to speak, then other conditions and diseases will be included. Personally, I say open up the floodgates and let it happen. But it's also important to note that the 2006 OAA reauthorization bill expanded the chronic diseases portion to include hypertension, obesity, and diabetes, which I just listed, just noted above. And the 2020 reauthorization amended the OAA section to add language to the definition of disease prevention and health promotion services to include prevention of sexually transmitted diseases and examples of evidence-based disease prevention and health programs. So the question I see is, one, whether the prevention and mitigation of the effects of HIV and AIDS can be accomplished under OAA without including HIV/AIDS in the list of chronic diseases, and two, if HIV/AIDS prevention and mitigation is already covered under the OAA, what are the incremental benefits in specifically identifying HIV/AIDS as a chronic disease? So this gets into a little more dicier territory, so to speak. The suggested approach would be to investigate further in consultation with federal agency staff, congressional staff, et cetera, whether there would be a benefit to including HIV/AIDS as a chronic disease. And if so, we would then assess whether HIV/AIDS could be added to the list of chronic diseases. Prevention of sexually transmitted diseases could be amended to include treatment of or both. And now I want to explain a little bit more, go into a little more detail about what Ron was noting about the greatest social need. So as I mentioned earlier, Title III of the OAA requires programs to target or prioritize services to older individuals with the greatest economic and social need. Under the OAA, the term greatest economic need means the need resulting from an income level at or below poverty line. The term greatest social need means, and this is what the statute says, means the need caused by non-economic factors, which include A, physical and mental health disabilities, B, language barriers, C, cultural, social, geographical, and I stated that before above. But it also restricts the ability of an individual to perform daily tasks. So this is problematic for what we're trying to do. The ACL, the Administration of Community Living, is the primary sub-agency, as we noted, within HHS that is responsible for issuing policy guidance to state and local AA grantees. It's worth noting that in June, we submitted comments to HHS, and NMAC did, in support of including and expanding the list of chronic diseases to include HIV. But there was an August 21, 2021 letter. The agency specifically said the OAA has long required that funding be targeted to those that are in the greatest social need. And so in the same letter, it directs state agencies to ensure that plans, and this is part of what Ron said with President Biden's executive order. If the greatest economic and social need is the key driver of prioritizing funding for OAA programs, NMAC would suggest further consultations with federal agency and congressional staff. If the OAA is amended to include HIV, an HIV status within the scope of greatest social need, that would direct more funding to the HIV community. I also put quite a bit in my presentation anticipating questions. I won't get into the history of Congress, although I think it's very important that you know that the key people that we're meeting with are Senators Patty Murray and Burr out of North Carolina, and they're on the HELP committee, and then the HELP subcommittee on primary health and retirement security is where this bill with the reauthorization falls. That's Bernie Sanders and Susan Collins. And in the House, we have a champion in the House, Congressman Benici of Oregon. The ranking member right now is Fulcher out of Idaho. He's kind of refused to take our meetings, but we're not going to give up. And then in the on the education and labor, it is Bob Scott and Congresswoman Fox, who also is very difficult, but we nonetheless will continue. I'll pause there, Moises, and because I don't want to get into the back and forth with the Congress, but I'd be happy to talk and answer questions about our history and going forward. Thank you.
Excellent presentation. Great, Joe. Now we're going to have Joe, last but not least, and hopefully we'll have time for some Q&A after Tom speak. So Tom, please go ahead.
Great, thank you, Moises. As we mentioned at the beginning, my name is Tom Villa, and I'm here with the National HIV and Aging Advocacy Network. As I mentioned, this network was born from the HIV 50+ Scholars Program. So a group of about 12 of us, a number of years ago, embarked on this as our project for our year of service, if you will, and launched the network in January of this year with about 200 members. And I think that's really great as a good start. Today, with this webinar, I understand that we had 280, maybe closer to 300 participants. So that's really great. I think on the sobering side is that in our regular monthly committee meetings and other monthly activities, that we see a relatively modest participation. So some of our committees only have 3 or 4 people who come on a regular basis. And many of our members, as we've surveyed them both in our individual committees and across the whole network in late May of this year, many of our members mentioned that although they support the work that the network is doing, that they have many other outside commitments, and it's difficult for them to commit to doing work outside of an event like this. So they could not commit to doing things like leading a subcommittee or a working group, or to doing committee work outside of the meeting itself. So I think that's one of the challenges looking forward that we need to consider, is what kinds of activities, what kind of events, how do we form ourselves as a community of advocates? How do we do the work that we're trying to do in light of the various commitments that people have? So now in terms of some of the key policy issues and advocacy issues that we've worked on this year, I've represented the network to the Federal AIDS Policy Partnership and the Working Group on HIV and Aging, and we meet monthly. This is a national organization and focused on policy issues. And we have recently signed on to a letter opposing, for instance, a bill that was introduced in the U.S. Senate called the PrEP Access Bill, but it would have potentially diverted funds away from HIV care services in the Ryan White program to pay for PrEP, and we don't think that's an appropriate use of care service dollars. And I'd like to thank Jax Kelly for a good policy analysis that he did as part of that process, and also to Mike McGinn, who participates in those meetings with the FAP working group as well. On the research front, a small group of us, including Moises, Jules Levin from the National AIDS Treatment Advocacy Project, Jeff Taylor from the HIV and Aging Research Project in Palm Springs, and Moises. So a small group of us are continuing to work with a group of federal officials on prioritizing research around HIV and aging. And this is kind of tough going, and we can talk more about this in a bit, but I'll say that not enough is being done quickly enough, as everybody has mentioned on the panel today. On the good side, the Ryan White program, HRSA and the Ryan White program are in the process of implementing an implementation science project focused on how best to implement new models of care at the clinic level for people who are aging with HIV. So that includes 10 clinics across the country. It'll run for 3 years, so through 2025. And I think our job as advocates is to make sure that we make this an issue in all of the planning groups, the Ryan White planning councils that we serve on at the local and state level, to make sure that funds are in place and ready to be allocated down to the clinic level quickly as results from this ongoing implementation science study come in. So it's a 3-year period. We need to be working now to make sure the money is there, ready to go. Also, for individuals who have their health insurance through the Centers for Medicaid and Medicare Services, so Medicaid or Medicare, there currently is not any kind of a national priority project or special project underway, and that's something that we need to change. So it's an area where much more advocacy is needed. And similar, when it comes to the Affordable Care Act and commercial health plans, we need to make sure that we're advocating for more and better services for people who are aging with HIV across all insurance plans, regardless of insurance. At our network level, one of the things that we have tried to do is to roll out through the NMAC newsletters, through the NMAC email distribution list, and their Facebook group, action alerts that make it easy for you to know how you can take actions quickly in order to voice your opinions on certain issues, and we'll continue to do that. But going forward, it's going to be important for all of us to think about how we can come together to have the most impact. I think that in addition to the federal advocacy that my colleagues have talked about today, I think that one of the really critical challenges that we'll face is that a lot of the work that needs to be done has to be done at the state and local level. And so that will involve each and all of you. And we need to think how we coordinate and support that work across the country. It's a big challenge, a big job and a big challenge. So on the uplifting side, we have a new cohort of HIV50 plus scholars starting at the end of this month. They'll be meeting in person at the US Conference on HIV/AIDS and bringing with them, I'm sure, fresh ideas and new leadership for the new year. So please support them. Please consider joining the network. You can find out how through the NMAC website. And I think all of us now will be available for questions, Moises. If you have questions, or if we're going to take audience questions, we'd be happy to answer questions people have. Thank you.
Wonderful. Excellent, Tom. Very concise. I love how you present. I mean, everybody, you go like very to the point. So let's just open it up for question and answers. I know those will be provided by Chip, right?
Yeah. Mm-hmm.
All right. So do we have any questions?
Not at the moment. We've had a couple of requests for direct contact information from some of the panelists. I just want to check with the panelists if it's okay to share email addresses with attendees.
Yep.
Okay.
So no questions?
Not at the moment, no.
All right. So I'm going to ask a question. So, I mean, knowing that, you know, we all have been working, and I think it's great what we cover in certain areas, and I putting this together, I tried to make sure that, you know, the different projects that were around were identified to have a niche within the broad advocacy arena that we have in front of us around HIV and aging. So how would you, what would be your recommendation in terms of like, and I'm going to ask first to Ronald and to Joe, in terms of working around the Older American Act, we have some work that we need to do at the state level. We have some work that we need to do at the federal level. What would be the best way to coordinate and find synergy among those efforts? And also, what would be the best way to also involve the community, or when would be the right time to involve the community in terms of like, you know, giving them a voice also to participate in that advocacy process?
I can go first if you want, Ron.
Go ahead.
And that's a great question, Moises. I think one of the things that you could do, there is no specific time, right? And so what we're trying to do is raise this awareness with Congress, because only Congress can put it into statute. And for all the good that President Biden has done, you know, the next president can undo it. And so what we would recommend is if, for example, if you're a part of the AARP, if you belong to AARP, or one of the many aging communities in this country, associations in this country, is to start raising the awareness that you're living with HIV, you're a senior, and you would like the states to be, you would like to be included in these state programs, because they are very important. And I think once, my very first boss was Ted Kennedy, and he used to say one person in the office is worth $1 million on the mall, the National Mall here. And he was absolutely right that one person in the member of Congress office is worth 1 million people marching on the mall. That is, they will change their mind often if it's a constituent. So make your voices heard. Now, we don't have the talking points yet because we're still meeting with stakeholders. And we will, as Tom noted, we will put things out as they become relevant to let people know that we are working. But right now, it amounts to those 8 members of Congress and senators that I mentioned. The buck stops with them, whether we get included or not. Ron, I'll toss it over to you.
Thank you, Joe. And I'll be supplemental to what you've said. First, in terms of the Older American Act and the kinds of actions you laid out, and to get to some of the points that Moises said, I made a note to myself, invite Joe to a HAPAC meeting so we can talk more about that. And I made a similar note with Tom's presentation. So that is to say, we need to be talking more with each other. The good thing is that, as I said in my presentation, there is an increase in attention, increase in the number of groups, both and individual advocates, but we all can't be going in separate, different, overlapping, conflicting, bumping into each other. We need to be working together.
Yes.
Because the amount of work that needs to be done is so great, and the talents among us are so fantastic that when we combine them, we become a force. So taking advantage, the FAP working group is an arena in which we can work together. AIDS United is doing work. The Gilead grantees, including ANAC and the programs that are working with Ribbon, and really congratulate Ribbon for taking a coordinating approach to make sure that we multiply our efforts and not counteract our efforts. So I think this webinar, the efforts that we're doing, we need to be in communication. We're not competing with each other. We are supplementing and dividing the tasks. State level tasks that can need to be done. I think in terms of the Older American Act, whether it's advocating legislative change at the federal level or getting the states to do more. These are the things that we need to do.
Very important.
If I could just add one more thing, I also encourage us to work closely with the National Working Positive Coalition that's led by Mark Misrock, and of which I'm the current chair. That organization, we need to build our own resources in the people living with HIV community. There's a lot of work that needs to be done. There are folks that we clearly can train to do some of these things that we need.
Absolutely, absolutely. And then Mark is part of the FAP working group, which, I will invite you, Vanessa and Linda, to also come and participate. And I think that while this advocacy effort happens, state level, local level, federal level, I think the work that, is happening with Tom and the National Advocacy Network, right? That we are there. It's great to see them organizing and pulling people into, because we're going to need community behind this. Also, the work that you, Vanessa, you're doing, you and Linda, in providing technical assistance to these organizations that are doing already work around aging in the community. So the same question that I asked to Joe and Ronald, maybe to Vanessa and Tom, in terms of how do we find synergies and how do we make sure that, like we said, en la unión está la fuerza, which means together we're stronger. So how would be your vision to see that happening between these two initiatives?
Did you want to go first, Tom? Okay, thank you. So I agree with everything that Joe and Ronald said, and thank you both for your comments. I thought they were really effective. The synergy is for us to remain committed to the cause of ensuring the survival of people living with HIV. I sometimes think we get caught in the minutia, and if we can remember that we are on a mission to save lives, and I know that everybody here knows that, but we have to keep saying it out loud so people really get that we're doing all this work for a purpose. That's what I think.
Thank you, Vanessa.
And I would mention or point out as a reminder to all of us something that Ronald mentioned, which was that despite whatever progress may be made at the federal level today, that could theoretically be undone by future administrations. So I think that one of the things that we need to probably embrace as a strategy for all of the advocacy work we do is to work top down. So to focus some efforts at the federal level and trying to make all the progress we can at the federal level with the administration, with Congress, with whatever other organizations or advocacy groups we may be able to get as allies. But we also need to focus on bottoms up or grassroots efforts at the local and state level. We can make excellent progress at the state level, as Ronald mentioned initially, with the 3 states that have already designated our groups as part of the groups at greatest social need under the Older Americans Act. So even if there were negative changes at the national level, at the federal level, let's say, those state designations don't change. So they're still in place. So I think we need to be working both grassroots up and top down. And that goes for funding for research. It goes for efforts to get more funds to the clinics or the practices providing services to people aging with HIV, et cetera. So across the board, I think both the top up or top down and bottoms up.
Excellent, excellent. I think that with this, we leave this question open to the audience about there are groups that are involved and committed that have the purpose of making changes around this community and the services we get, and we invite you to come with us, right, and help us move our agenda forward. Unfortunately it's 4:03, so we need to close our webinar. I want to thank you, all of you. You were excellent, and I feel it was so comprehensive, all the presentations coming together, that I hope we inspire many, many people to get involved in this advocacy path. All right, so thank you again and have a wonderful weekend.
Thanks you.
Thanks,
Bye-bye.
everybody.
Thanks everybody for joining.
Thank you.